Lacertus syndrome is proximal compression of the median nerve at the elbow. I had a carpal tunnel done by an excellent surgeon a number of years ago, and although I was better, I still had persistent symptoms. He was kind enough to even redo it, and I still had persistent symptoms. Years later, I met Dr. Elizabeth Hoggart in Vancouver. She was speaking at the same meeting that I was. Much to my surprise, with simple physical examination, she made the diagnosis of Lacertus syndrome in me. 2 months later, she sent me this video of her doing this wide-awake Lacertus release in a young woman in whom she had demonstrated weakness of flexor carpi radialis, flexor pollicis longus, and flexor digitorum profundus of the index, preoperatively, just as she demonstrated it to me in Vancouver, because I had the same symptoms. Here she is examining that same patient immediately postoperatively, showing return of power of those muscles. The return of power in this patient was very impressive, particularly in view of the fact that doing this operation with the wide-awake approach made it a simple 5-minute procedure like carpal tunnel surgery. Reading the excellent papers published by Elizabeth and her father, Carl Hoggart, also helped convince me that a good simple first step to releasing pronator syndrome was simply to divide the Lacertus. If that didn't work, I could still do the large operation for pronator syndrome, which is frequently described.
Make your fist and flex your wrists. Now, resist as I push down. And resist. And again, resist. And resist. Okay. Straighten your fingers. Flex your thumb. And resist as I push up. And resist. Straighten your fingers. Flex your thumb. And resist as I push up. And resist. And resist. Flex your fingers. Keep your index finger flexed. Flex on this side. Keep your index finger flexed. And flex. And flex. And flex again. Make a fist. Tighten your biceps. And relax. Is this painful?
It's uncomfortable.
Fist. Tighten your biceps. And relax. Extend your elbow. That painful?
Yes.
It was really tender when she pressed on my median nerve under the Lacertus. And if patients have this tenderness sign, weakness of FCR, FDP2, and FPL, I am now willing to operate on them. They may also have numbness in the palmar cutaneous branch of the median nerve, as well as persistent numbness after carpal tunnel release, as I had in my left long and ring fingers.
Yes. Flex your thumb.
Okay.
Okay. Keep it flexed. Keep it flexed.
Wow.
Flex your fingers. Keep it flexed. You can off the table. That's good. Flex your wrist. And keep it flexed. Did you feel the difference?
Yeah.
Yeah. All right. Time to suture up. Now we finished surgery, 2 minutes ago? Flex your wrist, flex your fingers, all of your fingers. All right. Keep it flexed. And keep it flexed.
You can't do it. It's just amazing.
All right. And flex your thumb and keep it flexed. Flex your thumb and keep it flexed.
I got an immediate return of power right on the operating table and in this immediate post-operative examination. Also, I got rid of the persistent numbness that I had in my long and ring fingers after my 2 previous carpal tunnel releases. I now pay more attention to patients who tell me that they did not get complete release of their symptoms after surgery. I like to inject at least 30 cc's of local anesthesia above and below the superficial fascia, but not underneath the deep muscle fascia. I want to keep my motor nerve alive for intraoperative testing of muscle power, which I do routinely. Although nobody knows why muscle power comes back immediately, it may be related to releasing the flow of large molecules up and down axons when you take your foot off the garden hose by releasing the Lacertus fibrosus, as suggested by Dr. Elizabeth Hoggart. One way or another, this operation has worked well in my hands and is simple to perform, like a carpal tunnel release. In a way, both operations are quite similar. We are releasing a tight fascial band that is compressing the median nerve at the elbow and the wrist joints. The option of more aggressive surgery, as in pronator syndrome, which is classically described, still remains for the surgeon to perform if he